Good afternoon. This is Dr. Amit Kochhar, Director of the Facial Nerve Disorders Program at the Pacific Neuroscience Institute in Santa Monica, California. Today, as part of our series on management of the facial nerve patient and management of facial paralysis, we have the honor of having Dr. Howard Krauss speak. Dr. Krauss is one of the founders of the Pacific Neuroscience Institute. He is clinical professor of ophthalmology and neurosurgery at the John Wayne Cancer Institute and a surgical neuro-ophthalmologist. He has vast experience in not only neuro-ophthalmology and general ophthalmology, but also oculoplastic surgery, among other fields related to skull base and orbital surgery, and has made significant contributions to the field over the years. Today, he'll be discussing eye care for the facial nerve patient. Thank you, Dr. Krauss, for joining us.
Thank you, Dr. Kochhar, and thank you for the invitation. Uh, Let me state that I have no financial conflicts of interest in this material. Our listeners may already be familiar with the Pacific Neuroscience Institute, but I'm so proud of what we've accomplished that I can't help but reiterate and redescribe that we are a multi-specialty group dedicated to the neurosciences, and our specialties include neurology, psychiatry, neurosurgery, otorhinolaryngology, audiology, neuro-ophthalmology, interventional neuroradiology, neuro-oncology, and neuroendocrinology. And if any of our listeners have figured out that I've left something out, let me know and we'll add another specialty as well. But the philosophy in our group is that by bringing multiple specialists of different background and training together in one institution, that number one, we can be more efficient in taking care of our patients. And number two, we can learn from one another, assist one another, and be more innovative in developing and bringing better treatments faster to patients in need. For example, in facial nerve problems, I think it's delightful that we have a ENT facial nerve specialist such as yourself in the group and an ophthalmologist who can collaborate with you and many other neurologic specialties that can help assess the facial nerve and treat the facial nerve patient as well. Facial nerve disorders do affect the eye, and that's because branches of the facial nerve are responsible for innervating and controlling the orbicularis muscle. The orbicularis muscle is a circular muscle around the eye socket that extends from the bone of the eye socket into the eyelids and is the muscle responsible for blinking our eye and closing our eye. Facial nerve patients may have weakness of the muscle or outright paralysis of the muscle. And patients who have recovered partially from facial nerve paralysis sometimes suffer with what we call synkinesis, where they may have a facial movement that then involuntarily causes a blink or involuntary closure of the eye. And another interesting synkinesis is what's called crocodile tears, where some patients unfortunately have to deal with the social embarrassment of having a tearing eye during times of conversation or at mealtime. We won't go into detail today, but facial nerve disorders also include hemifacial spasm, which can be a particular problem for patients with involuntary blinking and spasm and fasciculation of the muscles around the eye. In understanding facial nerve disorders, we could take a step back to have a anatomy lesson. The facial nerve fans out across the face to innervate and control muscles of the forehead, around the eye, the cheek, and around the mouth and in the neck. And although the orbicularis muscle is at the junction of the upper and mid face, There are actually three different branches of the facial nerve that do supply some innervation and control of the orbicularis muscle. And impairment in any of those branches can lead to a weakness and difficulties with blinking and secondary irritation of the eye. Most people don't think about it, but the facial nerve also innervates salivary glands and the tear gland. Most people think that glands function passively and secrete the necessary moisture, but in the absence of innervation from branches of the seventh nerve, those glands and the tear gland or lacrimal gland in particular don't function as well as they should. And dry eye for the facial nerve patient is not simply a function of exposure of the eye and impaired blinking and closure of the eye, but also is a function of impaired tear production. So let's consider what a blink does. A blink reforms the tear film. Think of the film of a soap bubble, and we've all had the experience of blowing a bubble and watching the bubble thin out. And when there's a thinning of one portion of the bubble where the film loses its integrity, the bubble pops. And similarly, with each blink, the margins of the upper and the lower eyelid come into apposition, and you can think of that blink and opening of the eye as redistributing a new tear film across the surface of the eye. And in between blinks, that tear film dries and breaks, and then the tear film dissipates, so that even in those who have the opportunity to have a complete blink or complete lid closure, if the blink is not frequent enough or the tear production is not good enough or the quality of the tears is not good enough, then there's a repetitive breakup of the tear film and drying of the eye and irritation of the eye. So the blink recreates the tear film, it redistributes the moisture of the eye, and there's also a pumping action where the blinking will move the tears and debris in the tears from lateral to medial, from the outer part of the eye to the inner part of the eye. We have tear ducts that are in the inner corners of the eyelids that conduct our tears into a lacrimal sac and then down through the nasolacrimal duct into the nose and down the back of the throat. And that blinking action and pumping action is important in terms of normal conduct of tears and any debris that may be carried in the tears. And absent that blinking action and conduct of tears away from the eye, there can be a buildup of tears, spilling of tears down the cheek. There can be an accumulation of mucus and a significant increased risk of secondary infection. So the pumping action that is inherent to a complete blink is very important. An incomplete blink, also known as lag of thalamus, leads to a early breakup of the tear film, leads to dryness of the eye, leads to surface breakdown, which produces pain and tearing and redness, and in advanced cases may lead to corneal ulceration, and with inadequate attention could lead to loss of the eye. So as one sees, an incomplete blink is a failure of the tear pump, and secondarily there can be spillage of tears. And as illustrated here, with enough laxity of the orbicularis muscle, there's also an outturning of the lower eyelid known as ectropion, and exposure of the mucous membrane surface of the inside of the lower eyelid may produce a great deal of swelling and redness and irritation. So the most important thing for the eye and for vision in the face of facial nerve weakness or paralysis is protection of the cornea. The cornea is the front clear window of the eye, and the first line of defense in protecting the cornea is lubrication. And frequent use of viscous, preservative-free lubricating eye drops is essential. I haven't found that there's one particular brand of preservative-free drop that's superior to another, but I do find a great deal of inter-individual difference. So for one patient, one brand may be the best, and for another, a different brand may be the best. So feel free to go down the aisle and try a variety of different brands. And each brand also very often will come in different viscosities. In general, the thicker the drop, the more viscous the drop, the longer it will last. But sometimes some people may have discomfort from a drop that is too thick. And of course, with increased thickness of the lubricant is greater blurring of vision. Apart from eye drops, which should be used in the daytime, thick ointments or gels should be used at bedtime. And the thick ointments and gels may also be used during the day for more advanced cases when the lubricating drops themselves are not adequately effective. But of course, the thicker the gel or the ointment, again, the greater the blur of vision. So again, the first line of defense is lubrication, frequent, viscous, preservative-free, drops in the daytime, thick ointments or gels at bedtime. Beyond lubrication, one may consider as a second line of defense moisture chambers or eyelid taping. Illustrated here are a variety of moisture chambers which can be found online. Many neighborhood pharmacies will not carry moisture chambers, but they're readily available online. A search for ocular moisture chamber will produce a number of samples and vendors from which one may choose. For those who wear spectacles, there are also inserts that can be applied inside the spectacles that improve maintenance of moisturization of the eye in the daytime with spectacle use. And in the use of tape to tape the eyelid closed at night, which is very effective. Be aware that some tapes can be more irritating than others, and it's important to use a tape with a less irritating adhesive. Paper tape is usually gentler than a variety of other tapes. The most important thing is to be sure that the eye is taped well enough to maintain closure during the night, or in the absence of taping, that there's adequate ointment or gel or protection from a moisture chamber to protect the eye through a night of sleep. The third line of defense may include eyelid surgery. The upper eyelid may undergo either a muleirectomy and or a gold weight implant. The lower eyelid can have a lateral canthal suspension to correct ectropion. And there could also be implantation within the lower eyelid of autologous tarsus or ear cartilage to elevate the eyelid margin. There are some aficionados of a spring implantation into the lids to help maintain blink and closure. My own personal experience has been limited with the use of spring implants. I've not performed them on my own, although I've consulted and cared for many patients who've had spring implantations, and I've been most impressed by the frequency of breakage and need for repair and have found that for many patients it's unsatisfactory, but there have been some patients with great success with spring implantation. In more severe cases, sometimes a torsorrhaphy is required. Torsorrhaphy is not our first choice because it does create some modest degree of disfigurement where the eye is not as open and visible. But again, it's important to be able to protect the cornea. Regarding the muellerectomy procedure, this was published in 2005 by Bart Free and colleagues, and I have found it to be very effective and rewarding in terms of improving the ability of maintenance of a improved tear film. It doesn't restore normal blinking action, but it can narrow the opening of the eye to a aesthetically pleasing one, and also as it narrows the opening of the eye, it also helps to preserve more moisture. The muellerectomy procedure can be combined with autologous tarsal implantation to elevate the lower eyelid, and it can be combined with tarsal strip procedures to correct ectropion of the lower eyelid, which can improve both form and function of the eyelids. These are some examples from that 2005 paper which reported the results of muellerectomy. So you can see preoperative photos on the left side and postoperative on the right, with the upper illustrating in primary direct position and the lower illustrating in closed eyelid position. It's a definite improvement. We still at times will implant gold weights into the upper lid to help lower the eyelid position. These are very effective in the daytime, but unfortunately, because they take advantage of gravity, are not always the best and most effective during sleep. So we've touched on a few of the things in relation to facial nerve paralysis, means of care and treatment, both for the patient and the patient's family. And we've discussed some of the surgical procedures which may be helpful for the patient suffering with facial nerve weakness. Thank you, Dr. Kochhar, for having requested my comments.
Thank you, Dr. Krauss. We have time for a few questions, so we'll take questions from the audience, and we've been having them in the chat. The first question comes to us asking about selective neurolysis. Have you had any experience with that procedure for the eye, specifically going in to cut one of the facial nerve branches to the orbicularis oculi or any other facial nerve branches? Has that something that has come across your career or been in vogue in the way it is now among certain surgeons?
Facial nerve neurolysis has been used as an effective palliative treatment for some patients with essential blepharospasm and hemifacial spasm. Again, remember that a neurolysis is intended to weaken the action of the muscle. So while we're improving and reducing problems with spasm, such as is often done with Botox, we don't want to exchange spasm for paralysis. The other problem with neurolysis is that nerve fibers like to regenerate. So sometimes the neurolysis procedure, even if effective, may need to be repeated. But neurolysis is a very effective procedure to have in one's armamentarium for the treatment of essential blepharospasm and hemifacial spasm.
Great. You touched upon the dry eye attributable to lacrimal gland denervation if the facial nerve is injured. Is there any understanding as to why some patients regain that function and some don't, or is it luck of the draw based on the severity of the Bell's palsy or Ramsay-Hunt disorder?
I don't know that we really know. Much of what we know in medicine, we know by clinical observation. And just as there can be some partial facial nerve regeneration to improve muscular control, there clearly is regeneration for reinnervation of the lacrimal gland. And we know that there can be a aberrant regeneration as well, such that fibers that should have been innervating muscle contraction end up to the lacrimal gland, which is the mechanism by which gustatory or crocodile tearing occurs.
Do you have any thoughts or experience performing the corneal neurotization procedure to help improve sensation of the eye for those that have loss of their corneal sensation?
I don't have any personal experience with it, but I've been impressed with some of the reports that I've read. Now, of course, most facial nerve patients, fortunately, do not also have fifth nerve problems with sensory loss. But a sensory loss of the cornea, in and of itself, even with normal facial nerve function, can lead to significant damage to the cornea. And when one in combination has both sensory loss from fifth nerve problems and facial paralysis, that can have a rapidly moving, devastating outcome. So corneal neurotization procedures, again, I see as valuable for those cases.
One patient has stated that they've used eye drops, but that they have significant pain or discomfort, and it's not just one eye drop that causes that problem. How do you counsel patients like that when we need to make sure that they're continuing to lubricate the eye in the face of this discomfort?
It's hard to convince someone that something which is causing them discomfort is good for them. I like to start with the analogy of a paper cut. All of us have had a paper cut, and we forget about it until our finger gets wet. And then when the finger is wet, it's painful all over again. Similarly, those people who have dry eye problems are not aware that they have dozens, if not hundreds, of microscopic abrasions on the surface of the cornea. Most drops have a significant component of salt. So just as we hear the expression of pouring salt on a wound, you're pouring salt on a abraded eye, which is irritating. So once there's a understanding that it's really the salt of the eye drop which is producing that burning irritation, I challenge my patient to put the drop in frequently enough such that they don't have those chronic microscopic abrasions, and therefore the pain of the installation of the eye drop goes away. Sometimes I ask my patients to do a 3-day test where they will commit themselves to putting a preservative-free lubricating drop in the eye every hour during their waking hours. And then to ask themselves at the end of the 3 days, how does the eye feel? How does the eye drop feel when it goes in? And that gives them the personal experience as well as some insight that with a frequent enough use of the lubricating drop that discomfort goes away, and moreover with a frequent enough use of the lubricating drop that their eye remains more comfortable, less red, less teary, and in most cases with better vision.
Great, thank you. A couple more questions. One regarding acupuncture and Eastern medicine. Is there any role for that in the management of synkinesis and ocular spasm from facial paralysis?
I don't know. I live and practice in Los Angeles, and there is no Western or allopathic medicine practitioner in Los Angeles who doesn't have a fair number of patients who are also taking advantage of Eastern and alternative medicine. And indeed, we have MDs who practice both allopathic medicine and Eastern medicine. So many of my patients will afford themselves of acupuncture and a variety of other treatments, and anecdotally, some derive some significant benefit from it. So I never object to the use of acupuncture or other therapeutic modalities in addition to all that we may have to offer.
What about electrical stimulation? Is that something that you've seen helpful or hazardous?
I don't know. I know there have been some proponents of electrical stimulation in an effort to prevent muscle atrophy. Some who have even claimed that it improves regeneration. As a facial nerve expert, I would defer to your experience in that regard as to whether or not it may be helpful.
Yeah, our experience uh, with in the facial reanimation world has been that electrical stimulation during the period of acute recovery when the nerve is paralyzed or the face is paralyzed is not helpful. If anything, we believe it can overstimulate the muscles and make them more sensitive to unwanted activity. There is some belief that once the face is moving and the patient is going through a physical therapy regimen, that at that time, some very gentle, low dose electrical stimulation can be helpful. But you're correct in saying that the verdict is still out. There's no one to show that that is really beneficial. But anecdotally speaking, I found it to be exceptionally harmful in the early stages when patients are still recovering. Last question here comes from a patient who's considering getting cataract surgery. Obviously, patients with facial paralysis keep going on and living their lives. Some may want to get LASIK surgery, some may want to get cataract surgery, other types of procedures on their eyes, blepharoplasty, cosmetic procedures. Is there any surgery that you would say is a contraindication, and what should patients ask their physicians, or what should they make sure they talk to their physicians about before embarking on any of those other ocular procedures after they recover from their paralysis?
That's a great question. And it's important to realize that in every specialty of medicine and subspecialty of medicine, that sometimes if an appointment is on calendar for cataract evaluation, that the ophthalmologist may not necessarily look carefully or inquire carefully about the history. So if you know that you have had a facial nerve paralysis in the past, um, it's important for you to let any of your eye care practitioners in general know about your facial nerve history. It can have an effect on even something as simple as getting a new eyeglass prescription or being refit for a contact lens. And certainly it can have an influence on one's candidacy for surgery and potential complications and outcomes in surgery. In LASIK, for example, and a variety of other refractive surgeries, if one has an impaired blink or a problem with dry eye, in that the LASIK itself sometimes increases dryness of the eye, that can lead to a poor outcome. For cataract surgery nowadays, um, we're not so concerned about the ability of the eye to maintain good health and have a good recovery in the small incision cataract surgery in general. But sometimes cataract surgeries are done with what are called premium lenses, and especially with the multifocal lens, which is intended to provide clarity of vision both at distance and near. If there's a problem with the tear film, which often occurs in patients who have had facial nerve problems, then that can diminish the quality of the outcome. Certainly, blepharoplasty is a significant problem in the facial nerve patient. because even without excessive removal of skin, there still is some fibrosis occurring in the eyelid that's had surgery, and some impaired blink, and some increased dryness following blepharoplasty. So, in consulting a cosmetic surgeon, head and neck facial plastic surgeon, or oculoplastic surgeon for blepharoplasty, again, it's critical to share your history of any facial nerve disorder that you may have had before. So, the important thing to recognize is that having had a facial nerve problem does not preclude you absolutely from having other procedures, but it should be discussed with the surgeon before planning surgery.
Great. That was incredibly informative. Thank you so much, Dr. Krauss, for sharing your time with us. For the audience, this will be posted on our Facebook site as well as the pacificneuro.org website, along with our other lectures that we've previously recorded and the ones that we'll have in the near future. Thank you for your time. If you have any questions, you can email me directly at amit.kochhar@providence.org. That's amit.kochhar@providence.org. And if there's questions for Dr. Krauss, I'll relay them to him directly. Have a wonderful day. Thank you very much for your time.
Thank you.